How's it going, guys? Very easy question for psych. Some of you will know the answer instantly. That's okay. Um, and there's some high yield points I want to make, okay? Because some of you might actually think there could be a mini erratum here. Holy shit, but there's not. But there's just some high yield points I will talk about, as I just fucking said. So before we get started, please subscribe to my channel. I really appreciate it. Give the video a like. I really appreciate it. Find me on Instagram at Mehlman_medical, MEHL_MAN_medical. The link is down below. Find me on Telegram. Recently created a Telegram group and channel. Links are down below. Now let's start the clip. 19-year-old woman, 2-year history of schizophrenia. Okay, that's what this is, schizophrenia. We're handing you the diagnosis. This doesn't need to be a big fucking 12-line paragraph, okay? 10 days later, she develops severe muscle rigidity and abnormal eye movements. Temperature is normal, 98.9 Fahrenheit, and the question is just asking the most likely or the most appropriate treatment. So some of you will say, OMG, severe muscle rigidity, she was given an antipsychotic. This must be neuroleptic malignant syndrome. It's not, okay? Because the temperature is normal. So you need to know that if you're given an antipsychotic or spiridone, D2 receptor antagonists, it can be a typical or an atypical, okay? Doesn't matter. This is an atypical. But if you get severe rigidity plus no fever, holy shit, that's going to be acute dystonia, not neuroleptic malignant syndrome, all right? So abnormal eye movements, this is referred to as oculogyric crisis. It's part of acute dystonia. You can also get cramps of the hand, okay, and torticollis, so tightening of the muscles in the neck, crooked neck, but no fever in acute dystonia, all right? Whereas neuroleptic malignant syndrome, fever. So let's just walk through the answer choices here. We'll go backwards. Choice E, scopolamine, wrong fucking answer. This is a muscarinic receptor antagonist used for motion sickness. Now, this drug in and of itself, the yieldness is not exceedingly high, but what is very high yield is that we treat motion sickness with muscarinic receptor antagonism. And I've seen other questions, so I'm sort of amalgamating the points here because I was going to talk about choice B anyway. Diphenhydramine is an H1 receptor antagonist, first generation H1 blocker. First generation, okay, H1, not 2. That has anticholinergic side effects, okay? Nasty anticholinergic side effects, which can actually make it effective for motion sickness. So I've seen questions where they give you someone who's going on a whale watch and they're going to take a drug for motion sickness, and you're like, oh, okay, like scopolamine, it's not listed. And then diphenhydramine is listed. And that's because they want you to know muscarinic receptor antagonism. Or they'll tell you diphenhydramine was given for motion sickness, and they'll say, which of the following properties of this drug makes it effective for this patient? The answer is M receptor antagonism, muscarinic receptor antagonism. Tangential point right there, but very high yield. Nevertheless, scopolamine, wrong answer. So choice D, ropinirole, wrong answer. This is a D2 receptor agonist. Now, some students will conjecture that if you have antipyramidal side effects as a result of antipsychotics, that you can just reverse them with D2 agonism. I don't believe I've really seen that on NBME material. It's more something we read in resources, okay? Like for neuroleptic malignant syndrome, as an example, it's like, oh, just reverse it with bromocriptine, right? Some resources will mention that. Haven't seen it as far as I can recall, okay? And even the fact that I have to think about it, just I don't believe I've seen it. Or if maybe once, but it's not something that clearly is on the top of my head. Okay, it's not high yield to reverse with D2 agonism. But ropinirole is a high yield answer, as well as pramipexole for restless leg syndrome. Okay, so restless leg syndrome we treat with a D2 agonist. The most common cause of restless leg syndrome actually is iron deficiency anemia. That's high yield for step 2 and 3 in particular. So it's usually seen in pregnancy because of dilutional anemia. So if the woman, usually are due to menses, so if the woman has normal iron levels, then you just give the D2 agonist. Otherwise, first you're going to make sure her iron is normal. Wrong fucking answer. Choice C, dronabinol, wrong answer. This is actually THC. Okay, this is man-made cannabis. I have seen this, not as a correct answer, but I've seen this floating around as incorrect answers on some of the psych forms for 2CK, all right? So it's notable that you're at least aware of this drug name. You're like, oh, okay, that's like THC. That's man-made cannabis. Okay, gotcha. Just be aware of it, but it's the wrong answer. choice B, diphenhydramine, is our correct answer here. So as I mentioned before, it's a first generation H1 receptor antagonist. H2 blockers, in contrast, are for stomach acid, okay, like cimetidine, ranitidine, but H1 blockers are for allergy. So of the H1 blockers, we've got first generation, such as diphenhydramine and chlorphenomine, and then we've got second generation H1 blockers, such as loratadine, okay? So the way you differentiate the second generation H1 blockers from the H2 blockers, which sounds similar, is the second generation H1 blockers are AD-INE, loratadine, okay? Whereas the H2 blockers for stomach acid are cimetidine, ID-INE, all right? ranitidine, ID-INE. So diphenhydramine, chlorphenomine, they're first generation H1 blockers, and we do not like to give these for strict anti-allergy application anymore because of their myriad of side effects, okay, namely the anticholinergic ones. So they can cause sedation, but anticholinergic being anti-dumbbells, that's a long discussion of itself, but dumbbells being the mnemonic for cholinergic side effects. So diarrhea, urination, meiosis, so that's pupillary constriction, bradycardia, bronchoconstriction, excitation, neuromuscular, lacrimation, salivation, sweating. And then so the opposite of dumbbells, like constipation, urinary retention, mydriasis, pupillary dilation, etc. So anticholinergic side effects are what can occur with first generation H1 blockers. But we want anticholinergic effects to treat acute dystonia. Okay, that's your high yield point here. Is this is acute dystonia? How do we treat it? Answer: antimuscarinic effects, which we get through a first generation H1 blocker. So another point I was going to make, because some of you will be like, oh, there's a mini erratum here, which there's not, but benztropine can also be a correct answer for this. Okay, so the answer would either be listed on USMLE as benztropine, which is a muscarinic receptor antagonist straight up, or if it's not listed, we give a first generation H1 blocker, such as diphenhydramine or chlorphenomine. The psych forms want both. Okay, very important you know that. So whilst, once again, this is a first generation H1 receptor antagonist, you should essentially view diphenhydramine, chlorphenomine as just synonymous with muscarinic receptor antagonists because of their nasty anticholinergic side effects, and they can be used for motion sickness, as I said before. They also have anti-alpha-1 adrenergic effects and can cause orthostatic hypotension / fainting, okay? Dantrolene, wrong answer. This is for neuroleptic malignant syndrome if the patient had a fever. Okay, the patient does not have a fever, so it's not neuroleptic malignant syndrome, all right? If we had rigidity / fever in response to succinylcholine when patients undergoing general anesthesia, that would be malignant hyperthermia, but the mechanism is the same as neuroleptic malignant syndrome, which is the ryanodine channel. Ryanodine channel allows calcium from the sarcoplasmic reticulum inside the cell, allows calcium to move from inside the sarcoplasmic reticulum into the cytosol. Okay, and clearly there shouldn't be high calcium in the cytosol like that. So the cell has to use a lot of ATP to bring that calcium back into the sarcoplasmic reticulum, and that produces heat. Okay, so when the ryanodine channel is stuck open, we get neuroleptic malignant syndrome / malignant hyperthermia, and we give dantrolene, which will close the ryanodine channel. Okay. Sometimes they can give you a vignette of neuroleptic malignant syndrome, so rigidity and fever after an antipsychotic is given, and then they'll say the most appropriate treatment for this patient is what, and the answer will just be decreases sarcoplasmic calcium release, okay, because that would be the mechanism for dantrolene. So this was a bit of an extended clip, actually, in terms of my discussion here, but there's so many high yield points to make. You know the deal. I'm going to continue to make more content. If you like my stuff, subscribe to my channel. I appreciate your time. That's it.